Good afternoon. My name is Lisa Barnes, and I am a professor and cognitive neuropsychologist at the Rush Alzheimer's Disease Center in Chicago. And today I would like to talk about my research on cognitive and brain aging in older African Americans. By way of an outline, I will briefly review disparities in Alzheimer's disease and cognitive decline. I will describe two of the cohort studies at Rush from which most of the data I'll share come from. Then I'd like to spend the remaining time discussing the complexity of disparities in cognition and how we've tried to embrace this complexity as a means to better understanding its origin. And for this, I will focus on various risk factors for Alzheimer's disease or cognitive decline, and racial differences and patterns of neuropathology. The demographic profile of our nation is changing. By 2050, racial and ethnic minorities will make up the largest segment of the adult U.S. population. Minority populations, including African Americans and Latinos in particular, are disproportionately burdened by chronic illness, disability, and cognitive impairment. In fact, the Alzheimer's Association estimates that African Americans are about 2 times more likely than whites to have Alzheimer's disease. To illustrate this point, I am showing data from YCAP that the Alzheimer's Association included in their facts and figures. YCAP is out of Columbia in New York. And what you can see is that at every age category, African Americans are in the green color, and Hispanics are in the sort of the light blue color. At every age category, African Americans and Latinos have a higher proportion of persons with Alzheimer's disease or other dementias. More recent data out of Kaiser in California show a similar pattern, with African Americans having a higher incidence of dementia than any other racial or ethnic group. Now, what I would like to argue is that there are some issues with studying cognitive aging in African Americans that may have an influence on these data. We know from cognitive aging studies that older racial and ethnic minorities tend to perform at lower levels on cognitive function tests, on average, than older non-Hispanic whites. But cognitive function is influenced by multiple cultural and social attributes outside of cognition itself. And I'm showing these things on the slide, like quality of education, early life factors, language, and so on. And many of these factors are associated with race and ethnicity. However, most research on disparities in cognitive aging is cross-sectional, making it difficult to compare across race given these various factors. Here I show 2 examples that are typical of the field where we try to understand racial differences by either comparing young and old across race or stratifying by age within race and ethnicity. The right panel shows data from 2 population-based studies, MIDAS, which is the National Survey of Midlife in the United States, and YCAP, the cohort that I showed you earlier from Columbia University. What you can see is older adults perform worse than young adults on cognitive function tests, and African Americans perform worse than non-Hispanic whites. The panel on the right shows the prevalence of cognitive impairment in the Health and Retirement Study. At every age category, Hispanics and African Americans have a higher prevalence of cognitive impairment than whites. The point is, although aging is fundamentally a process of change over time, relatively few studies employ longitudinal approaches to examine racial differences in cognitive aging. Now, although cognitive aging has not been a primary theme of life course epidemiology, we know that performance on neuropsychological tests is shaped by environmental experiences across the life course, from the prenatal period to old age. I show this example of the relative importance of exposures acting across different life course time windows in terms of the natural history of lung function. Minority populations may have different exposures to major risk factors at conception and across the life course that may influence adult outcomes. In fact, given the profound differences in social conditions across race and ethnicity, it's likely that racial ethnic disparities in cognition in late life reflect a cumulative effect of disadvantage across the life course. Understanding the key pathways, the most important time periods of exposure, as well as disparities in exposures across the life course, would help us in designing and prioritizing efforts to reduce racial disparities in cognitive impairment. In fact, most of what we know about cognitive aging comes from studies with majority whites. This is data from one of our studies at Rush, and it shows a scatter plot of trajectories of decline over time in a random sample of whites who all started the study without dementia at baseline. The green line represents people who never developed dementia, and the purple line represents people who developed dementia over the course of the study. The scatter plot shows significant heterogeneity, but when you fit a regression line through the raw data, you can see that the decline is really driven by people with dementia. In our longitudinal cohort studies of minorities, when we compare aging trajectories between African Americans, Latinos, and whites, we see that cognitive decline is really age-related. It doesn't appear to be related to race or ethnicity. On the right panel, we're comparing blacks and whites, in which we divided the baseline age range into 5-year intervals and plotted the predicted 5-year paths of decline in semantic memory and perceptual speed. Whites are the green line, and blacks are the blue. As you can see, there are large differences in level, but rates of change are mostly similar. In the panel on the left, we're comparing the trajectories over time between Latinos and non-Latino whites. And again, significant heterogeneity is evident, but the slopes representing change are nearly identical. We have recently shown the same finding in our population-based study called the Chicago Health and Aging Project. In analyses adjusted for age and sex, African American participants performed significantly worse than white participants at baseline. By contrast, African American participants' cognitive performance did not decline more rapidly compared to whites. You can see the lines at age 68, age 73, and age 78 are parallel, suggesting no racial differences in rate of decline. So these data suggest that disparities in cognition, where we see level differences, the differences are already in place by age 65, suggesting that we may need to intervene earlier. Childhood factors will mostly be addressed by policy, but midlife may represent a critical window for prevention and intervention studies. So the question becomes, can we identify risk factors that may be important in explaining these differences? The identification of risk factors is also important for prevention. Here I'm showing you a slide from Sperling et al. That was published in 2011 for the new guidelines. And as captured in that study, as captured by the most recent criteria for Alzheimer's disease, we know that the disease is on a continuum from normality to mild cognitive impairment to Alzheimer's disease dementia. So given the fact that African Americans start out lower on cognitive function tests, it's likely that the persistent differences in level of cognition is what is responsible for the higher risk of disease. Essentially, because they start out lower, they hit the threshold for dementia faster. So given that Alzheimer's is on a continuum, what we really want to do is to be able to intervene in the preclinical stage and identify risk factors that may help us to slow the rate of decline. So I would argue that prevention is an important action area. especially given the fact that we don't know what causes Alzheimer's or loss of cognition, and the current medications that we have for the condition do not change the course of the disease. In order to prevent Alzheimer's dementia, we need to first identify genetic and/or environmental risk factors, and then determine the biologic pathways linking these risk factors to disease. So that way, we can develop strategies to prevent disease, either by altering life behaviors or identifying druggable targets and developing effective therapeutics. In order to do this, we need large studies that include people without dementia, who agree to detailed assessment of risk factors, blood donation for genetic testing, and annual testing so that we can document the disease when it happens. And we need to include diverse samples of adults beyond those who show up for medical care, because we know that people who show up for medical care may be different than those who are living in the community. We have 2 such studies at Rush: the Minority Aging Research Study, known as MARS, and the Rush Memory and Aging Project, known as MAP. MARS consists of more than 700 older African Americans, and MAP consists of more than 1,400 whites, both without known dementia at the time of enrollment, living in and around Chicago metropolitan area. All agreed to annual detailed clinical evaluation for common chronic conditions of aging, with detailed evaluation of risk factors and blood donation. All MAP participants agreed to organ donation at death as a condition of entry into the study. Organ donation is actively pursued in MARS as an optional component of the study that participants can choose to endorse at any point during the study. Importantly, both studies have the same cognitive battery and a common core of risk factors so that the data can be merged to examine differences across race. Participants are recruited through continuing care retirement communities, senior buildings, senior organizations, and churches, and also word of mouth. There is a strong community-based approach to recruitment, with our philosophy being in the heart of the community, ever seeking to win the community's heart, to emphasize that recruitment into these types of studies, especially with diverse populations, requires significant relationship building and giving first before we ask for anything. Both studies follow a longitudinal cohort design where persons enter the study without dementia at baseline, and a number of risk factors are documented. We follow people annually, allowing us to relate risk factors to change in cognitive function over time and incident disease, and in those persons who come to autopsy, we can measure a range of pathologies in the brain and relate the risk factors and cognitive performance while they were alive to patterns of pathology in the brain, all in a single study. Our clinical diagnosis of dementia is the same in both studies and follows a 3-stage process, including computer scoring of the cognitive test battery, clinical judgment by a neuropsychologist, and diagnostic classification by an experienced clinician. The dementia criteria we use in our studies follows the NINDS ADRDA criteria. A summary diagnosis based on a review of all clinical data by an expert who is blinded to pathology is made at the time of death. So when we think about disparities in cognitive aging, disparities can occur in at least 2 ways: at the level of the risk factor itself or in the relation of the risk factor to cognition. We and others across the country have published on a number of established risk factors listed here on the slide. Most of these are non-modifiable. Our interest at Rush is in identifying modifiable factors, factors that we can change or alter in some way, and our group, along with many across the country, have published several factors that increase your risk for Alzheimer's disease or cognitive decline, and others that appear to be protective against Alzheimer's disease or cognitive decline. In the interest of time, I'll give you just a couple examples of how a risk factor can either vary across race at the level of the risk factor and or have a differential effect on decline across race. The first example is with the ApoE allele. The ApoE4 allele is the most well-established risk factor for Alzheimer's disease and cognitive decline in whites. And although African Americans have a higher frequency of the E4 allele, which is well established, in many studies it's about 1.5 times more in African Americans, its effect on both Alzheimer's disease and decline is weaker in African Americans than whites. Here you can see with performance on working memory tasks. If you're white and you have the E4 allele, you decline much faster. But you don't see this effect in African Americans. The lines are on top of each other. Another example is with an infection called cytomegalovirus. This is an infection that's usually acquired in childhood and lays dormant for years until reactivated in times of stress. CMV, as it's known, is much more prevalent in African Americans, as you can see in the table, demonstrating the mean IgG levels at different ages for African Americans and whites. Despite having a higher frequency of CMV among African Americans, however, the effect on cognitive decline and risk of Alzheimer's disease is the same in both populations. And in the graphs, I'm showing you on the left panel the effect of CMV on cognitive decline. So people who had the CMV infection are represented with the red line, and they decline much faster than those who did not have CMV, as shown with the blue line. Similarly, on the right-hand side is the risk of Alzheimer's disease, and you can see that people who were CMV positive, as shown with the red line, had a higher hazard of Alzheimer's disease than people who were CMV negative, and this did not vary by race. So we can see different effects of risk factors across race, but the reasons for the disparities in cognition between African Americans and whites is still unclear. Well, what if we examine culturally relevant risk factors, that is, risk factors that are particularly relevant for African Americans? When we think about African Americans, we're really talking about the social experience. How does the social experience influence cognitive decline? Another potential avenue that we can explore to explain disparities is neuropathology. There are few studies of neuropathology in African Americans and none in African Americans without dementia. We know from numerous autopsy studies in whites that the underlying pathologic basis of Alzheimer's disease is heterogeneous and frequently mixed. So one relevant risk factor that we have looked at in our studies is perceived discrimination. Discrimination is an important psychosocial stressor for African Americans with links to numerous adverse health outcomes. Some studies have found that it partially explains disparities in health. We examined the association of perceived discrimination with performance on our cognitive function tests and found that people who reported more discrimination performed more poorly on episodic memory and perceptual speed tests. We also found that discrimination is associated with higher levels of C-reactive protein measured in the blood, suggesting that potentially inflammation may be a pathway linking discrimination to poor health outcomes, including cognition. We've also recently reported that a measure of perceived stress, which assesses the degree to which one finds their life unpredictable, uncontrollable, and overloading, is related to faster rates of decline in African Americans. This figure shows that people who scored at the 90th percentile on the scale, meaning that they reported more perceived stress, in the blue line, had a faster rate of decline than those who scored at the 10th percentile. And interestingly, the effects were found in the same cognitive domains that we found effects for discrimination in episodic memory and perceptual speed. There are a number of other important culturally relevant variables that we and others have published that appear to have an effect on rates of decline in African Americans. So people have looked at neighborhood factors and found that living in neighborhoods with community resources, proximity to public transit and public spaces in good condition is associated with slower rates of cognitive decline. People have also reported that life experience variables related to baseline cognition attenuates the effects of race, ethnicity, and education. And we have reported that food deprivation and body size in early life is related to decline in African Americans. Finally, I like to turn to neuropathology as a potential source to explain the disparities. All of our studies at Rush follow the same autopsy protocol. Participants who agree to autopsy receive a rapid autopsy with short postmortem intervals. Removal of the brain, preservation, and processing is uniform and standard across the studies. In all cases, we obtain cerebrospinal fluid, cut the brain tissue into slabs, obtain digital pictures, and fix and freeze the tissue. Fixed tissue is then blocked for diagnosis, and there is a standard macroscopic and microscopic assessment. We examine the common pathologies that cause dementia in old age, including Alzheimer's disease, which we use the Bilskowski stain in 5 brain regions, and the diagnosis is present if we find intermediate or high likelihood by NIA Reagan criteria. The neuropathologist is blinded to race, age, clinical, and diagnostic data. We also get CIRAD diagnosis and Brock score, which gives us the plaques and tangles separately. And the diagnosis requires at least moderate neuritic plaques in neocortical regions and minimum of Brock 3 to 4 limbic stage tangles. The other pathology we measure is cerebral infarcts. We assess chronic macroscopic infarcts, where the slabs are inspected, blocked, and microscopically examined. And we look at chronic microscopic infarcts. These are infarcts that are not seen grossly, but identified microscopically. We examine 6 cortical regions, 2 subcortical, and 1 brain stem. And the diagnosis is any macro or multiple micro infarcts. And then the third pathology that we measure is Lewy Body disease using alpha-synuclein, which is evaluated in multiple regions listed here on the slide. And the diagnosis is presence of Lewy bodies in any region. We also look at other pathologies that I'm not going to describe here today, but one recent one is TDP-43, which is important in frontotemporal dementia, and we found that it is highly present in people with and without Alzheimer's disease. So we recently published a study of African Americans and whites with dementia who were recruited from our memory clinic. When they died and came to autopsy, we examined the pathology in the brain and found that people had a wide range of pathologies, including Alzheimer's disease, infarcts, and Lewy bodies. Again, going back to what I said at the beginning of the presentation, that Alzheimer's disease is really a mixed disease. It's not just plaques and tangles. But what we found in this study was that African Americans were more likely to have a mixture of different pathologies as a cause of their dementia, as indicated in the pie chart where the arrow's pointing to the red slice, compared to whites who were more likely to have Alzheimer's disease pathology as a cause of their dementia, which is shown in the pie on the right by the blue slice. But these were clinic-based patients, and they may not be representative of the community. So what we really want to know is, how does this look in people who start the study without dementia? So we have been accruing brains from participants in MARS and MAP who started the study without dementia. And here I'm showing you data from the first 45 African Americans who died and came to autopsy, and they're matched 2 to 1 to whites on age at death, sex, and education. We can see that the only difference between the two groups was that African Americans had a higher percentage of people with the ApoE4 allele, and they were more likely to have a clinical diagnosis of Alzheimer's disease, but this only reached marginal significance. When we looked at the pathology of people who died without dementia, without a dementia diagnosis at death, so remember, everyone starts the study without dementia, and we follow people over time. And at the end of the study, these are people who, when they died, they did not have a clinical diagnosis of dementia. We found that African Americans were more likely to have Alzheimer's disease pathology, as shown in the blue, compared to whites. These results are different from the clinic-based sample. And because these participants did not have a clinical diagnosis of dementia, but had Alzheimer's disease pathology in the brain, it suggests that there may be some resilience markers in their brains that allow the pathology to accumulate, but they never experienced the clinical symptoms of dementia while they were alive. In fact, in our studies in whites, we know that close to 60% of cognitive decline is not explained by any of the common pathologies that we currently measure. This is likely the case in African Americans, but we need a lot more data to be able to examine this. So, in conclusion, I think there are several gaps and opportunities for health disparities research of cognitive aging, and we can ask ourselves, where does all of this leave us? I think there's at least 4 important directions we can take this research. First, with the changing demographics of our nation, non-Latino whites will become the minority. The current minority populations are underrepresented in clinical research. Even where we are secure that there is no disparity, we need to know more about these populations. We need to advocate for inclusion of minorities in clinical trials and studies that collect biospecimens like autopsy, neuroimaging, and CSF collection. We need to study minority health in its own right for its own purpose, because the drivers of disease and outcomes could be different. Second, we need more longitudinal designs so that we can distinguish factors that affect test performance from true change over time. Third, we have a very limited understanding of the biologic mechanisms underlying disparities. Therefore, we need biologic outcomes like genomics, proteomics, metabolomics, and so on. And finally, we need a better understanding of the factors contributing to individual differences in change, including conditions that are more prevalent in minority communities like vascular factors and certain social conditions. And I think we'll need to take a complex systems approach that takes into account the interaction of risk and resilience factors across the life course. To the extent that some of these factors are modifiable, they could represent a strategy to slow decline or improve function in late life. I would just like to end by acknowledging all the people who contributed to this work at the Rush Alzheimer's Disease Center, our funding agencies, and the participants of MARS and MAP. Thank you for your attention.